There is a generalized haze in both lungs with hardly any normal tissue visible. There is a very poor definition of blood vessels. Even the larger vessels in hyla are not visible bilaterally. Transverse diameter of heart is a bit bigger than half of the internal diameter of chest, or I can say the cardiac size is a bit bigger than the hemidiaphragm, suggesting cardiomegaly. But notice it's a mobile chest x-ray done on patient's bedside and is essentially an AP projection, and the cardiac enlargement could be because of projection rather than the actual representation of cardiac size on the film. Bilateral haziness is because of presence of fluid in air spaces which should normally contain air. Although there are few differential diagnoses, the appearance in this case is because of acute pulmonary edema. Pulmonary edema can be a result of acute changes, and it is known as acute pulmonary edema in that case, or can be a result of chronic process. Pulmonary edema refers to leakage of fluid from pulmonary veins into surrounding tissues, which initially happen around vessels, which decrease the clear definition of vessels in early phase. Later on, fluid enters into the alveoli of lungs, causing ventilation perfusion mismatch. Actually the ventilation perfusion mismatch happens as soon as fluid enters interstitium, because diffusion cannot occur. But it is more profound when the fluid enters into the alveoli of lung, and because alveoli of lungs are filled with fluid, the oxygen cannot be absorbed by the blood vessels that are surrounding the alveoli, which cause hypoxemia, means low level of oxygen. Interstitium of lung is a connective tissue and holds lymphatics as well as blood vessels. Lymphatics are responsible for absorbing excess fluid. Leakage of fluid from vessels into interstitium is a natural process and happens regularly, but the excess fluid is absorbed by lymphatics at a rate of 10 to 20 milliliter per hour. But then there's a limit as to how much fluid can be absorbed by lymphatics in a given time. Most common causes of cardiogenic pulmonary edema are left ventricular failure and mitral valve stenosis. Left ventricular failure, for example, because of myocardial infarction, i.e. heart attack, or because of mitral valve stenosis, leads to obstruction to flow of blood from left atrium to left ventricle, and hence increases pulmonary venous pressure. And it happens when pressure in pulmonary veins rises above 25 millimeter of mercury, which is osmotic pressure of plasma, means at this pressure contents of plasma can easily flow through the walls of the veins. Lymphatics simply do not cope with the amount of fluid coming in from vessels. Initially, fluid accumulates within interstitium of lungs, and it is known as interstitial edema, and then it enters into alveoli of lungs, and in that case it is known as alveolar edema. Finally, fluid enters into pleural cavity and is known as pleural effusion. So if you notice, left costophrenic angle is not clearly visible, and there is a small amount of pleural effusion in left costophrenic angle. Both interstitial edema and alveolar edema are identifiable on chest x-ray, and they have different patterns. Normal pulmonary venous pressure is much lower than 25 millimeter of mercury. When fluid initially accumulates in interstitial space, it is visible as increased linear markings. Some of these lines are known as curly A lines, which are normally found here. Some of these lines are known as curly B lines that are always found in bases, and they are horizontal lines, and they are nearly 2 centimeter long. So if you look at the lung base here, so you can see some horizontal lines clearly, 1, 2, 3, 4 and 5. So these lines are known as curly B lines. The vessels are never visible in this area, the normal vessels, and this is not a vessel, this is these are septae, and these are visible because of the accumulation of fluid within the septae. The septae get bigger and become visible as curly B lines or curly A lines. We do not have a good example of curly A line. Um, the word septa means dividing wall, and lung septae are thin layers of connective tissue which hold secondary pulmonary lobules within them. A secondary pulmonary lobule is simply a bunch of several alveoli which has a thin layer of connective tissue that is known as septa. Clear visibility of vessels in lungs is because of difference in density, as the vessels uh, have blood. The blood looks white, and the lung tissue, lung parenchyma, has air which appears black on X-ray. So the vessels that are white are passing through